Secretary Carey, thank you so much for being our guest speaker today. What an honor it is. I know you're a little busy right now, so
Well, I'm sure we're all busy running our businesses, running our organizations at the same time, dealing with the pandemic for ourselves, our families, for our communities. So yes, it is a busy time, but communicating and connecting is an important part of my role. So it's an honor to be with you all today, and looking forward to our time together.
yeah. Well, thank you so much. And I know that your background involves, I believe, cardiology. Would you tell us a little bit about what you did before you became the secretary? I believe you were in Roanoke.
Actually, Lynchburg,
Lynch-
but that's close, close. Thank you for the question. My most recent position, I was actually chief medical officer and senior vice president at Centra Health, not Centera, Centra, which is about $1 billion health system, 1,200 beds across 4 hospitals with about 60 or 70 clinics in South Central and South Side Virginia. I know Richmond calls Richmond Central Virginia, but geographically Lynchburg kind of is in the center, and it really took care of. Uh, it's really about the size of New Jersey, about 9,000 square miles, within a 30-minute of our clinic sites, and about a 500,000 Virginians and some in North Carolina were cared for. Prior to that, and I still am a cardiologist, I do a little bit of volunteer work, uh, but I was a full-time clinician, interventional cardiologist, catheterizations, angioplasties, vascular medicine as well, and helped run the Heart Center and the cardiac cath lab. So I was a partner at the cardiovascular group, and my wife and our 2 children live there for a little over 20 years, and still have deep roots in Central Virginia. So for me, I love clinical medicine. I still love it. I'm a volunteer vaccinator, and just connecting with individuals is a real thrill still. And it's just, I enjoyed the leadership aspect and developing a strategic plan and implementing that, and that led to my interest in policy. And also, I was the president of the Medical Society of Virginia back in 2009, 2010. I really enjoyed the public speaking, the advocacy, interacting with the General Assembly, and those two, a leadership role and that experience had me being interested. I was so pleased when the governor asked me to join his team.
Well, I believe I'm a little late with the congratulations, but based on your background and also your various interests, I'm sure it's a perfect fit, if that's appropriate to say, for what we've been dealing with since the pandemic began. I see that you have always had a focus and an interest in the Asian community, as well as low-income working families and children. And those have been the headlines, in COVID. Of course, everyone is affected, but certainly those groups have been in a sort of disproportionately affected through COVID. And we can circle back to that. But could you just give us an update, kind of a ground zero on where we are with COVID-19 and the vaccine? We can deal with those separately if you'd like.
Sure, be glad to. First, where we are with the pandemic. And now the good news is that now, after I'm looking at the 18th, so the 7th will be the anniversary of our first case. I will say I was at the second to last person-to-person session. I was getting a degree in a master's of healthcare management at the Harvard School of Public Health. And I was in Boston that Saturday, and I spent most of the time on the phone Saturday, Sunday, came home Monday. That degree was a kind of a 2/3 MBA, 1/3 public health degree. And I was so fortunate because, frankly, the social determinants of health aspect, not just the infectious disease, but public health response, was much of my coursework, as well as what I've been doing supporting behavioral health and the Virginia Department of Health. But now, almost 1 year into this, the good news is the rates are falling. We look at the new infections per day per 100,000. And in Virginia, we are today at just below 30, 28. Now, last fall, going into the fall, and we were concerned about our universities and our schools, we were at 8, 9. So clearly the amount of infection that we saw with the post-holiday surge, post-Thanksgiving, also people, when it's colder, we came inside, the the consequence of going to a social gathering outside your household, even if it was extended family members, much higher indoors than outdoors. So I think we saw that around Thanksgiving and certainly with the winter holidays. And we really peaked in January 17th in terms of the number of cases and also the number of hospitalizations that we saw. So fortunately, that has come dramatically down. We have not fallen as fast as the rest of the country. We've been very fortunate in Virginia that, we are, if you look at from the beginning, we're the 8th lowest state in per capita deaths and the 9th lowest state in per capita infections, and the only large state that has that few deaths. So it has been horrendous in Virginia. So many folks lost. Right now, over 7,000 Virginians lost from COVID. We just horrendous. But at the same time, I think our measures have really made a difference. So they are falling. We're the 6th highest infection rate right now because we haven't fallen quite as quickly. Now, we were not as high as some other states. So you tend to fall fast when you've been up very high, just part of the biological phenomena of that bloom. You see that in algae and in the Chesapeake Bay, and you'll see that in other biological phenomena. But we've weathered it well because we've really done a good job of committing to physical distancing beyond 6 feet, hand hygiene, wearing masks. And we're fortunate in that our more populous areas, Northern Virginia, Central Virginia, here in Richmond and Tidewater, mask wearing is adhered to with a greater frequency than it is in some of our rural areas. When it got going in far Southwest, with rates approaching 100 infections per day per 100,000, it was really just incredible spread. And it was similar to Tennessee and Kentucky and West Virginia and parts of North Carolina. So that all of that is good news. We're down almost 40% in hospitalizations now, 1 month after that peak on January 17th. So that's all good news. Right now, we're right at US is about at 25, and we're just around 30. So we are a little bit ahead, a little bit higher than other states. In terms of the regions of Virginia, the lowest region is the far Southwest. That was the highest region not all that long ago. That's at 16. And we've also seen the positivity rate come dramatically down. Today, we're down below 9% as a state, with the Northwest at 6% and Northern Virginia at just under 8%. So those are all good things that showing that our tests are reliably identifying most infections. If it's less than 10%, we prefer it less than 5%. So now to the vaccines. This is really where there's great hope, but we're going to need to continue to socially distance and do those precautions until we really achieve herd immunity. And that will be through vaccine, not through everyone getting infected, because in Virginia, the tens of thousands of people who would die if we had that degree of spread are just simply unfathomable and unacceptable. So where are we with vaccines? As of this morning, we have just under 1.5 million vaccines in the arms of Virginians. So we're really excited about that. We really did get a little bit slow out of the box, and that was pretty clear why, is that because of cold storage requirements of especially the Pfizer vaccine, we sent a lot of the doses to our health systems. One, they had the facilities, and two, they had the large 1A population, healthcare workers. Now, when that uptake was less than we expected 70, 80%, it was closer to 50%. And there were lots of doses on hand, and it took a few weeks for us to figure out how to transfer those doses efficiently and effectively to other vaccination venues, whether community-based with the Department of Health or with localities. We did learn that. That's where we went from, at one point we were 49th or 50th in use of our percentage of vaccines. Now we're, as of yesterday, I think we're 9th in the country and we're certainly been top 10 for the last 3 or 4 weeks, because we realized that our hospitals are doing great work, both on care of patients and in vaccination, but they're used to inventory, and inventory is not our friend right now. We got to get rid of everything that we get every week, certainly first doses, designated first doses, but have no longer than 7 or 10 days of second doses on hand. And as of this morning, 98% of first doses are in Virginians' arms and 58% of second doses. And those second doses will catch up because we began really aggressively getting all first doses out about 2 to 3 weeks ago. So that rise in second dose will come 3 and 4 weeks later, 3 weeks for the Pfizer, 4 weeks for the Moderna vaccine. So we're in a good spot. We could do, when we're looking and see we're doing 50,000 doses a day. I've been to Virginia Beach. I've been to the Arthur Ashe Center, did some vaccinating myself at Arthur Ashe. I've been to Chesterfield County. I've been to Hanover, been to Petersburg to 2 locations, Chesapeake. And if the snow hadn't occurred, would be at one tomorrow and through Saturday, but the ice. But observing that we could be doing 150,000 a day if we had the consistent doses that would justify that kind of infrastructure, because the localities, the National Guard, we're ready to go to scale. But when you only get, more like 20,000 first doses a day, based on the 130, 140,000 we get per week, it's really hard. Northern Virginia, Central Virginia, Tidewater, even Lynchburg and Roanoke could easily go to scale. And but without reliable supply every week at 250, 350, 400,000 doses a week, you can't build that and wait a month, 2, 3, 4 months for that to come to be. So we're excited where we are. Our goal is really 3 things. We've got to make sure that this is safe. We got to make sure it's equitable, and we got to make sure it's fast. No trade-offs. And getting equity and getting into communities that have been discriminated against, that have been, there's hesitancy because of the Tuskegee experiment, because of other bad experience, frankly, with the healthcare system. That trust takes time and a lot of retail communication and trust building and trusted intermediaries. So we're going to have to put a lot of extra effort, and we are, to make sure that we are not just reaching and offering the vaccine to our Latinx, Hispanic residents, to our African American residents, populations, for example, that have borne the brunt of the pandemic in Virginia, but that we're actually building that trust so people are saying yes to the vaccine, and that our numbers reflect what Virginia looks like. Our vaccine numbers should reflect what our residents look like. So that's where we are.
Yeah, and thank you for making the comment about the Tuskegee experiment, because I think a lot of people, unfortunately, the headlines, they'll touch on something and it creates sometimes more confusion than provides information. And the other thing is, with these disproportionately affected communities, there's also the concern where I can look out my back door and I have this huge yard and my neighbors are way over there. But if you live in a situation where you live right on top of other people, that's part of the issue, right?
Right.
And so the trust has been a concern. But I also wanted to circle back to the herd immunity. I heard about it, I read about it. Is it a real thing, and how long will it take for us to get there?
Yeah, herd immunity is a reference to cowpox and vaccinating herds of animals, domesticated animals, that even if you didn't get every animal vaccinated for a particular illness, disease that say cows have in a herd of cattle, if you got almost everyone vaccinated or everyone had a good immune response, none of them would get infected, because there just wasn't enough vulnerable individuals in the herd to sustain enough of the illness and enough of the transmission to go anywhere. So that's that idea. And for highly infectious diseases like measles, which is one of the most easily transmitted disease, you got to have about 90 or 94% of either had the disease and have natural immunity, or have been vaccinated and therefore have immunity through vaccination. And if it's if it's a non-deadly disease, then sometimes and there's not a vaccine. Herd immunity is achieved through everyone getting the disease and maybe having a bad cold or the like. But when it's something like COVID-19, that maybe 5 or 10 people out of 1,000 die from the disease, probably 10 to 20 times what influenza is, then you're not going to sit back and let it get transmitted from person to person, because there will be carnage. In fact, Sweden did that, and they have been vilified. And the numbers, look at their death rates and their hospitalization rates, have been much higher than other countries in Europe that have similar socioeconomic resources. So we're not going to let this people get infected, and everyone is not destined to get infected. Now, there are, again, if we allowed it to run unimpeded without all of our mitigation measures, then yeah, this would be it. People would have lived or died, but that's not what we're trying to achieve here. We're trying to create the greatest good for the greatest number and avoid as much illness and long-term disability and death as possible. So we need to get a lot of people vaccinated, and it's not as transmittable as measles. So we don't need 94%. And if you listen to Dr. Fauci or Dr. Osterholm, he's at University of Minnesota, the two gurus that I follow, you're talking around 80% or so. And we want to achieve that here in Virginia. And again, the good news is that the vaccines do, certainly the mRNA vaccines, the Pfizer and the Moderna, much stronger immune response than you get naturally. So that may be important as variants that take hold. That would increase the likelihood that those vaccines will be effective with a very, very strong immune response.
So you're saying that even with the variants, the Pfizer and Moderna vaccines have the potential to be effective?
Yeah, the variants that we talk about, they're different strains of the coronavirus, and the SARS-CoV-2 is the strain of the coronavirus. And then the variants are the subtypes that have mutations, and these are all generally mutations of the spike proteins. And those spike proteins are on the surface of the virus. It looks like a crown, hence the term coronavirus. That's how they look like under an electron microscope. That those spike proteins are how it attaches to the mucosa when it's transmitted, or also attaches to cells and then injects its messenger RNA as part of the infection process. So it appears that, and so the three that we follow, really, the B117 is the UK variant, the B1351 is the South African variant, and then there's the P1, which is more similar to the B1351, similar to the South African, is from Brazil. Those are the three that are most often mentioned, but in fact there are, and all three of those are in the US, and we've seen certainly the UK B117 in Virginia. And I had the opportunity to talk to Dr. Avula, and I talked to essentially the General Perna of Israel a couple of weeks ago to talk about their vaccine distribution. And in fact, within about a month, B117 took over, became 80 to 90% of all the strains in Israel. And actually, Israel has 4 to 5 times the infection rate right now that we do, at least as of 2 weeks ago. And so it is very infectious. And there's one study that suggested the B117 variant is more deadly. And the CDC estimates that as early as mid-March, it could be the dominant strain in the US. It's doubling, I think, every 10 days or so. So the good news is, even though it's transmissible, the same things work. Masks, hand hygiene, 6 feet, and stay home if you're sick. Those are the key 4 things, 4 behaviors. And there is a question in the UK, the 1351 variant, that the AstraZeneca vaccine was not as effective, but that's that needs to be confirmed. And that vaccine is one of the vaccines that we're hoping to get approval in the US. And all the manufacturers are saying, do they need to tweak it in order to improve effectiveness against some of those variants? But there are more than the vaccines have multiple proteins that they are reacting to, creating an immune response to. So it's not going to be an all or nothing. And it does look like the mRNA vaccines are effective. And again, the Johnson and Johnson, while not quite as effective in preventing disease, is highly effective at preventing hospitalization and death. And in the end, that's really what we care most about. So all of these vaccines, when they're available, as long as they're shown to be safe and effective, we'll get them out. And then if we need booster shots in the fall because there's better ways to protect against variants, then we can address that at a later date. But there is some coverage, and we're learning more about that every day. So a little bit longer answer perhaps than you wanted, but
No,
hope that was helpful.
yes, it was helpful. And you mentioned something about the variants, and that's kind of scary to hear. But of course, the information, we need to hear the information and the reason why we continue to need to wear masks. I have a question about the variants. I was having a conversation with one of the folks that we work with, and his 4-year-old daughter came home, came home from daycare and had the virus.
Mm-hmm.
And they think that she got it from one of the teachers at the daycare.
Mm-hmm.
And so they've all had to quarantine. She actually got quite sick. And I remember in the very early days, of course, things have changed many times in terms of our knowledge and our understanding of this virus. But do you think that children are being affected because of the variant, or was the potential always there?
I'm actually just quickly calling up the data from the cases across. We in Virginia, we've had over 55,000 cases, positive tests in those 10 to 19, and we've had 23,000 cases in those infections with those 0 to 9. Now, fortunately, we have not had deaths in the very, very young, but young children can definitely become infected. One of the things you mentioned, I won't call it rare, but it's relatively uncommon for, children generally come to school or daycare with the virus. Teachers come to school or daycare with the virus. We've realized that the transmission at school with normal mitigation efforts is relatively uncommon. Yes, there have been outbreaks, but nowhere like we see in college areas, like we're seeing at UVA, where I think they went forward with Greek rush, and they're having outbreaks at UVA right now. And I think they're shutting down the university, not in person to person for a period of time. So yes, children can get infected, and yes, they can transmit it. But in our original analysis this was like influenza, and where children are a important reservoir for the transmission. But that simply isn't as true with COVID-19. And what we've realized is that separate than the vaccine, but with mitigation efforts, that we can safely get both teachers and children back in school, especially our youngest learners, pre-K through, say, grade 5 or 6, where person-to-person learning is so important. And I think the other thing to realize, we're getting our kids back in school, and the governor has been very clear in his communication, as has the Department of Education, that every school division needs to have plans in place by March 15th to have options for face-to-face education. And that's because of the risk has been shown to be low, and the risk of continuing with exclusive remote telelearning is very high. We're seeing just I won't say an epidemic, but a huge increase in behavioral health challenges with our children and adolescents. And that's got to be weighed against what is a very low and manageable risk of infection at school, because generally it comes from in-house interactions or private interactions with people outside your household is where we're really seeing the big transmission. That was true in Thanksgiving and over the winter holidays. And I hope not, but we will look for a post Super Bowl bump. I hope our messaging was good.
Yeah. Well, with this child that was sick, the parent told me that they all quarantined. They were told that the parents had to quarantine another 10 days after the last symptom that that child experienced or something like that. But nobody else in the house was positive, and they're going to go through more test. But that was also interesting to me that she brought it home. The mother didn't get it, the father didn't get it, the sibling didn't get it, but they have to quarantine. I think it was beyond her last symptom.
Right, and that makes sense, right? Because let's say the last possible day that the child could have been infectious was the day that it was transmitted. And then the time between transmission and then it becomes an over infection can be 10 to 14 days. So that is simply it often is a month that you are in an isolation or quarantine. Isolation, if you've got the disease, it's called quarantine if you're a close contact. And I was a close contact with the governor. And I was in this, I'm home today because of the ice on the roads. Usually I am at work we can keep social distance at the Patrick Henry building, and a lot of people still do remote work. But my point is that I was in meetings for 3 days in a row with the governor, but we were more than 6 feet apart. We both had masks, frequent, wash in, wash out. We would say, going into a patient's room, you wash your hands on the way in, you wash your hands on the way out every time, no matter what. We do that on the way into a meeting and on the way out of a meeting. That if you do those things, not one non-household contact of the governor and first lady contracted the disease. There were 65 or 75 of us that met the criteria for close contacts that were quarantined. No one developed it because we did the simple things. The simple things done well are that's true whether it's the variant or not. And I think those are important to remember.
So I started wearing, I believe I read an article, and you may or may not have been quoted, so I won't blame you for this, I suppose, but I read an article about double masking. Mm-hmm. So now, not everywhere, but especially when I go to the grocery store, or what would you call, I guess, either medium or high volume areas, I put on a medically kind of mask, and I want to talk about that in a minute in terms of whether it really is. But anyway, I put on that mask, and then I put on my pretty mask, and I double mask going in. Does that really have any efficacy? Is there a reason for that?
And I have to say, I don't know the data on double masking. It does make sense. And by the way, I wear glasses when I'm I can see everyone fine here, but I tend to use a medical style mask, though it was bought at Dollar General, and they're readily available and have been for months. It just has a wire and I can pinch it on my nose. But cloth masks, as long as they're 2-layer, are pretty darn effective. I know the CDC has some recommendation about 2 masks. I think Dr. Fauci has started to wear 2 masks, and some people do. I do think it adds further protection. Whether it's absolutely necessary, I think the key is the 6 feet part in addition to the mask. So I think if folks want extra assurance, I think that's okay. I don't know if it certainly hasn't become the standard to double mask. Many people do. I certainly wouldn't fault anyone, and I got a feeling I don't have this last week's recommendation. So I know what I'm saying is generally correct, but we haven't said 2 masks are what you have to be wearing. And I think that was a response to the increased transmissibility, maybe 40 or 50% higher transmissibility of the UK variant, for example. So that's prudent. I do think not socializing with folks outside your household. And again, that's 6 feet, even if you're in the grocery store, for the minimum time to get your essentials. I think those are as equal to double masking. So I don't have, as you can tell, I don't have a strong opinion about double masking, but it certainly is reasonable.
Well, that makes sense to me. When you said something about washing your hands on the way in and on the way out, I try to get my family the minute you come home to hit the sink, and wash your hands. And I call it washing the world off your hands. But it's good to hear that as well as a common practice that we should all take a look at. If you don't mind, I'd like to circle back to the vaccines. You mentioned something about the vaccines and the cold storage needs. And then there seemed to be some changes in that information in terms of the source of the vaccine, Johnson & Johnson, Moderna, Pfizer. Do all of the vaccines have to be in cold storage? Because I know that I did see on social media some you guys were taking a hit a bit about the availability about the vaccine, and I know that that is linked to the storage, but is that across the board or will that change?
You had mentioned taking the hit. I think our criticism really was that transition I mentioned at the outset between doses and inventory that was existing on health systems, cold storage shelves, and then getting it out. So we really haven't had much criticism. I think there are about 38 to 42 states that would rather be Virginia than anywhere else. And certainly for the overall management of the pandemic by the numbers, we feel very fortunate, again, because the residents are following the rules, because great leadership from the governor, and also our hospitals, our civic organizations have really come together like never before. So all of that really good. In terms of the vaccine and cold storage, the Pfizer vaccine is unique in that it's like -70 to -85 Celsius. So it is very, very deep cold storage. The Moderna is less so. It's more the usual freezer. And the AstraZeneca, actually, my wife is a nurse. She's involved with a research group here in in Richmond, and it's very stable. It's a more traditional type of, I think, adenovirus-based vaccine. It just needs refrigeration and is stable for at least 30 days. So I'm not sure where Johnson & Johnson is. It's definitely not the deep storage, but most physicians' offices could handle the freezer type. The real challenge, and the reason we haven't gone predominantly to all pharmacies and all private providers at doctors' offices is because of the inventory issue. We really don't have enough vaccine that we can afford to have any of it sit as inventory. We got to get it out each week. So that's why we're using a different, more like Amazon delivering a package than going to a doctor's office and getting your usual flu shot each year, or even your shingles shot, for example. We are growing that as we get more supply and we could afford to have more inventory. We do know that the usual healthcare system will connect more easily for many into more vulnerable populations there. And also there's initiatives to expand the pharmacy. That'll start next week. And then there's a federal program to use our federally qualified health centers. But in terms of the main issue is with the mRNA, messenger RNA based viruses, based vaccines. They need to be stable, and there's a lipid coat, which is kind of a fatty, oily coat outside of the messenger RNA that's required for that to actually get into your body. It doesn't go into the nucleus. There's no virus, there's no infection, but it does have your own body make the spike protein and express it on the outside of the infected cells, and your body reacts to that and says, that's not the host, that must be a foe. So let's create antibodies to that. And with 2 doses, there is a profound reaction, which is why the second dose, like with the shingles vaccine, I'm not vaccinated, it's not my turn yet. My wife's a nurse, so she has been vaccinated, and she had no reaction to the first dose, but often there's a reaction to the second dose, which is how it works. You're reintroducing more protein, and you've primed your body to react to that protein to make that reaction even more vigorous so that you have very, very profound immunity going forward. So in any event, that needs a lot of stability for that messenger RNA with its lipid coat to stay stable. It's got to be very, very cold. One platform is the -70, and the other platform is closer to 0 Fahrenheit and maybe -10 or 15 degrees Celsius.
Okay.
So the other ones that come online will be easier to transport. But at the same time, I think we've learned how to do it. I think we really have learned how to use the other vaccines, and even if they're sent to a secondary site like a doctor's office from a health facility that has the deep cold storage, I think we've learned those logistics and how to get them out quickly.
Awesome. And you mentioned something about the second vaccine and having a more significant reaction. I saw someone on Facebook said who asked for prayers because she was getting her second vaccine, and so I didn't get it. What kind of reaction do people have to the second vaccine?
Right. It is a typical reaction to a two-dose. Am of the age that I benefit from the shingles vaccine. I had the original one-dose shingles. Now there's the two-dose, a little bit more effective vaccine. The brand name is Shingrix that I had in the fall and right before the holidays. It also produced, the first shot was, soreness like a flu shot. And with a flu shot, I always get a little achy. And again, that's your body reacting. That's your immune system turning on. But within 24 hours, I felt fine. With the second dose, I had a much more, a little swelling and a little redness and more body aches, more for say 24 to 48 hours. And for folks who have gotten either the Pfizer or Moderna dose, those are the kinds of stories they tell. Sometimes folks even can get some GI upset and a fever, and that can last a day or two. It would be unusual to last much beyond that, but you're not getting the infection. It's simply your body's, that's what a souped up immune reaction feels like. You're turning on the biological response of your immune system. And again, that is, a very few people have anaphylaxis, which is the profound reaction where you get swelling of the airway and dropping of the blood pressure. And that's why you need to have folks who can inject you with an EpiPen or epinephrine as the response, and why when you go to get your vaccine, first or second dose of the current vaccines, you'll have 15 minutes of wait if you've never had an allergic reaction to a medicine. I react to oysters. I had oysters once and my eyes swelled shut. I can eat cooked oysters, but I have that allergic tendency. So when it's my turn, I'll be in the group that goes for 30 minutes to watch a little bit longer. And if you have had the term anaphylaxis, that profound reaction people can get to peanuts or food allergies or bee stings when they have to carry their EpiPen, they will likely ask you to get the opinion of your doctor to make sure it's safe. That's the one group that likely needs to know that their doctor's on board. But in reality, the benefits will likely outweigh any risks.
Well, you mentioned the anaphylaxis, and I had that to Omnipac when I had a CAT scan.
Ah,
And yeah, but I can eat oysters and shellfish, so I don't really get that. But
right.
when you mention those kinds of reactions, is it necessary if you have an underlying condition, which is why you should be getting the vaccine? But is it necessary or recommended to call your doctor and say, hey, I had this reaction to Omnipac, and for me, my mother got Guillain-Barré after a flu shot, so I don't know what kind of category I'm in, but should we call the doctor before even going for the vaccine?
Well, I think that if you've got concerns and you need some extra reassurance, calling your provider, your doctor, your nurse practitioner is often a good idea. I would say, you reacted to Omnipac. I was an interventional cardiologist, so I use that all day long. Then some people will react to seafood. Some people react to what is called iodinated contrast material. You're not reacting to iodine, it's the organic compound, but we just consider those hyperreactors. So I think you likely will be in the 30-minute chairs with me, or when it's warmer, we'll have more drive-through places. But I think that if you've had, for example, you're undergoing chemotherapy for a tumor of some type, if you have an autoimmune disease, just touch base with your doctor to make sure that that's okay. That's not my area of specialty, and I'm not practicing every day like I used to. But what doctors and patients who've talked to their doctors tell me is that the benefits almost always outweigh the risk. If you are immunocompromised, that's a reason to get the vaccine, not get the vaccine. And because it's not a live virus, you're not going to get the virus from the vaccine. And maybe your body doesn't have, if you're immunocompromised or you're undergoing chemotherapy, you may not have as robust an immune response as you would have otherwise. But any immune response is generally better than none, so that you have protection against the virus.
Well, you just made the cost of the ticket, which wasn't anything, but you just made it worth it. I mean, so many people think that when they get those types of vaccines, they're actually getting the flu or getting the disease when they have the reaction. So that's a great, great dispeller of that myth and mystery. So thank you so much for that. One of the things I was wondering about is the various symptoms and the varying symptoms. One person might get the coronavirus and have a sore throat and maybe a cough for a day or two. Another person ends up in the hospital for 2 weeks, and they could be in the same age demographic, or could both not have underlying conditions, or could be different. But why is there such a range of reactions to this novel coronavirus?
The short answer is we don't know. We don't know. I mean, part of the reaction is the infection, the direct infection. And certain individuals, even without a prior exposure to coronavirus, don't get as infected. Their body seems to ward it off, and their viral load, the number of particles does not build up as quickly or to such a degree as other people, that whatever their natural immunity, maybe they had a corona. We all have been exposed to coronaviruses. So maybe the one coronavirus that she or he was exposed to had some similarity in the past, a little bit different than a neighbor or a sibling may have had. So that's one thing. And then the other, and I think is even more important variable, is how your body reacts to it. It's usually not the initial wave that is a harbinger of really serious outcomes, needing to be put on a ventilator, and the weakening of the heart muscle, the cardiomyopathy, or other life-threatening aspects to coronavirus infection. It's usually your body's own. It turns on your immune system in an uncontrolled way, and it's your body reacting against your body. And that's why simple steroids, not the anabolic steroids like used by bodybuilders and performance enhancing drugs, but corticosteroids that blunt the immune response. You may ask, well, gosh, why are we blunting the immune response? The immune response is what we want to keep us from the infection, but that's not the case. It's uncontrolled reaction to the infection by our immune system becomes the deadly element. And it's the inflammation of our lungs and these release of a number of chemicals in our bodies that are actually as toxic to our cells as it is to the virus. And that autoimmune, meaning reacting to our cells aspect of an uncontrolled immune response, is often, that happens at day 7 or 10. Someone's doing well, they're feeling good, they're staying at home, and then suddenly they get sicker and they're more short of breath, and they actually have had their immune system is turned on. So that's where some of the steroids can help that, and also the antibody treatments that are now available, especially for those who are at high risk should the infection become more severe. Those are, and President Trump had that, the so-called, I forgot, Bam Bam, which is the 2 antibody treatment that is available now, that we are trying to get our nursing homes and other places where high concentrations of vulnerable folks, that if they get infected, and they're intervened on early on, then you can prevent both hospitalization and serious complications, including death. So anyway, I went on a little bit long there, but I do think that's an important aspect of this.
Yeah, well, no, thank you. I appreciate you digging deep on these subjects. You said something, I don't know if I heard you correctly, but I've heard people say that everyone will eventually get the coronavirus. Is that true?
I don't. When you say that, it reminds me of the question that, well, let's just all get it, let it spread fast, and we'll get to herd immunity. But the problem with that is that literally millions of people more will die if you do that. So that's a pretty brutal way and unacceptable way to go forward. However, as our best belief is that this SARS-CoV-2 type of coronavirus jumped species, likely from bats, likely in China, likely last year, or 2009 or late 2019. That those coronaviruses, respiratory spread viruses, likely will be around for some time, and there may be other variants that are so different they are truly a different species, a different subtype, or really considered a different virus. I think they will be around, and hopefully most will be like most coronaviruses, not SARS-CoV-2, that cause a cold-like symptom, not something much more deadly that we're experiencing now. Now the question: will everyone be infected? I think if we figure out, this may turn in like influenza, that there are 3 or 4 different types that we predict will be prevalent next year. That's what we'll put in a yearly coronavirus vaccination. It may turn out like the flu shot. It may be more intense. We have to do it in the fall again. If, let's say, we think, I pray that President Biden is correct, we'll get everyone vaccinated by July. That would be fantastic. We're going to need 400,000 doses per week in Virginia by May to get there. Then we may need a booster, either in the fall or early winter next year if there are different variants that need better protection. So I think I'm splitting hairs here. I do think that everyone may indeed get infected, but it doesn't mean that everyone has to have a full-blown COVID-19 infection. I do think we're going to continue to be exposed to variants of COVID for the years to come, and we may need additional vaccinations in order to decrease the chance that we're infected and decrease the chance that it will become a pandemic again.
So my husband and I were traveling, and we saw folks get off a boat, and everybody in that group had on masks. This was in early 2019. And we stood there and went, oh, that's ridiculous. We had no idea what was coming. But we were talking the other day, and are we in mask now for the foreseeable future? Is that going to be the recommendation?
Yeah, I don't know. But culturally, it's interesting because of the respiratory infections that were prevalent in Asia. You would see folks coming either back from Asia or Asian tourists or business people coming to the U.S. in airports, whether on the West Coast or East Coast. You'd say, wow, that they're being particularly cautious, aren't they? But they had lived through a SARS, a decade or so ago, or a little, between a decade and 2 decades ago. So there was reason for that behavior to be instilled in the population. I suspect the behavior, we hope, will be instilled as long as it's needed. I don't know whether, I do think we're going to get to a time where masks are less needed, but I will say, and it's quite interesting, this has been the lowest infection rate for influenza, I believe, on record. I mean, we'll double check that, but there's very, very little influenza being spread this year.
Mhm.
And it's because of our behaviors with the SARS-CoV-2 virus and COVID-19 has also been effective at preventing the spread of influenza. Yes, there have been very good vaccination rates for influenza this year, which is a good thing because we didn't want what we were calling a twindemic happening with both SARS circulating and epidemic levels of influenza spreading. But what we've seen is that influenza rates are greatly reduced by those same behaviors in addition to uh, the vaccination. And the vaccination, by the way, for influenza is typically 50 or 60% effective. And that's why when these rates of above 90% effective, or even with the J&J vaccine, essentially 100% effective at preventing serious illness, hospitalization, and death, uh, these are tremendously effective vaccines. Even the ones that are purported to be, quote, less effective, unquote, they're still pretty darn effective. If that was available right now, sign me up. I'll take the J&J today, and it'll get us through the next 6 months, and we'll see whether I need a booster or not. So I think J&J goes to the FDA committee, I believe, next Thursday. So that's a week from today's the 18th. Yes, I think it's either next Thursday or perhaps next Friday. So we may be getting vaccine that J&J into Virginia as soon as 2 weeks from Monday. So that's cause for great optimism.
Well, I want to respect your time and also,
Oh my gosh, I can't believe it's flown by. I really thank you so much for such great questions, and I really appreciate the attention.
well, if we can take just a couple more minutes of your time, Secretary Carey, I was just noticing in the chat, we do have a couple of questions if you have time. One of the questions is the efficacy of the flu shot affected by the vaccine? So I guess if you get a flu shot and then you get a coronavirus, a COVID-19 vaccine, I think that's what he's asking. Are they?
Yeah, I don't think there's any reason to think that the efficacy of your of the one vaccine affects the efficacy of a different vaccine. In fact, when my wife went to get her shingle shot, it was also time for her flu shot, so she got both at the same time. Boom, boom. And there's no evidence that affects the efficacy. Is there? I don't think. Yeah, I don't think there's a reason to think that they would cross-react in either a positive way or a negative way.
That's great. That's great to hear. Also, Al Hinkle would like to know if what your opinion is on is your opinion on dealing with the stress and depression of the pandemic. You mentioned the importance of in-person schools, but of course, there are adults also dealing with some negative effects of being away from people.
I think that we will be dealing with this. Thank you for that making that point. And I think there's going to be a number of other, I would call collateral pandemics that come from this. And one is, you pointed out, depression, anxiety, social isolation. We're seeing it in a rise in substance use disorder, a rise in overdoses from opioids, for example. And I think we're going to see it that schools and teachers counselors were the number one referrals for child protective services. Those referrals are way down because the kids aren't out in public to see, hey, Sally's, something's going on here. Let's ask some questions. And having the safety net there to make appropriate referrals and to do appropriate investigations. So there's that. But there's also the true behavioral side. We're herd, we talk about herd immunity, we're herd animals. We are, small bands of hunter gatherers. That's our roots. And we need each other. And many seniors, many others are isolated, both physically, which can be appropriate out of that household, but that makes us emotionally isolated and more likely depression is significantly up. So we need to find that balance of connection. And I think it's going to be easier. I pray for the warmer weather because people can socialize safely outside if they keep keep it to your household, but it's much easier to keep 6 feet away um, uh, outside, the risk is definitely lower, and that's consistent with the governor changing some of the guidelines on gatherings to larger sizes, because outside, frankly, they can be very safe as long as we keep that distance and there's great air circulation. But back to the other pandemics, we're seeing other vaccination rates way down. We're also seeing pap smears and mammograms way down, colonoscopies way down. So there's a great deal of deferred medical care, both preventive and screening, that has not occurred. That's going to be there. So we've got to be ready to deal with those elements as we come out of this. And a renewed effort for vaccination, renewed effort for behavioral health screening, all critically important. And that's the other pandemics is the financial crisis for the most vulnerable. The economy in Virginia actually is doing well, but that's because the Newport News shipbuilding and our healthcare systems and Northrop Grumman and our major defense contractors. Thank goodness we have that here. We haven't had to make huge cuts in our base budget to fund our essential services. Other states have had to do that, but that does not mean that our entertainment sector, our hospitality sector, and a number of frontline workers have been devastated by this pandemic. So we've got to make sure we're prepared to do that, and we're trying. There's been good federal help. Rent assistance just was another round of rent assistance was announced by the governor. But there is we're going to have to deal with the lingering effects, even when we figured out the infectious disease aspects of this. There's the lingering and I've just scratched the surface with all of those implications.
Right. Yeah. Well, we at the Innsbruck Foundation normally are putting on a lot of events. And so our complete strategic plan hangs in the balance. And we await with bated breath what will happen, in the next, probably by quarter, probably by Q3 to see if we can put on those events and get people back together. And I would do it. I think most of the people I've talked to every day will do it if we have to wear 3 masks, but just so we can get back together. We have a couple of other questions. If you don't mind, I can send them to Jennifer and your great team that put that helped me put this together.
Sure. Well, maybe one more, and then if there's a remaining one, you can send it.
Great. Oh, thank you. So one of the questions is, let's say that the efficacy of the vaccine is 90%, which you mentioned. Is there a way to determine if you're in the 10% where it doesn't take?
Yeah, I think, theoretically, you could do a titer of, and what they do is they do a dilution. They take out your blood, they take out the red cells, and that serum that contains your antibodies, they can do a test of reactivity, and then they dilute it and do a test of reactivity, then dilute it. And that's where they have it. Your titer is 1 to 32, meaning you lost reactivity when you diluted it 1 to 32, the fourth or fifth or sixth cut in half of the added water to dilute it out. So you could do all those things. In reality, unless you're clinically, there's not an indication as to do that for an individual. I do think that the key thing, though, with the vaccines is that all three that we've talked about, Moderna and Pfizer and J&J, that I've seen their data. I have not seen any U.S. AstraZeneca data yet. They're essentially 100% effective at preventing hospitalization and death. So there clearly is a reaction, and that's pretty darn effective. So I'm not. I'd have to be shown where a strategy of knowing what your titer was led to better outcomes as opposed to just adding expense and worry.
So much like the changes in the way, well, maybe not as varied, but, again, talking about how one person gets the coronavirus and gets simply a cough, and another person might be hospitalized. And these are things that are probably will be born out of response, out of experience. We're still pretty new at it, but I was astounded.
One last point. It's possible. The holy grail of the testing side was to have just a strip that you ran through in the inside of your mouth, and it could say, red or green, you either got it or you don't, and it costs 98 cents. So you could literally do it 3 times a week, and everybody just did that as part of but that never has happened. It's possible that there would be a finger stick test that could go on some sort of strip that had all of the chemicals and reagents in it uh, that would react and say, green, protection above a certain level, red, lack of protection. I doubt there's that itch is worth the scratch. But that they could, that is theoretically, you could get a home test for that, and that would be maybe cheaper and more accessible than a complex titer for your antibodies. But just thinking out loud.
Okay. There is a question about the monoclonal antibody treatment. I don't know if you want to speak on that.
Well, that was, you were saying the Bam Bam treatment, which there is the monoclonals. One of the preparations actually has monoclonal, means one line of antibodies that are all reacting against the same molecule. And there are the Bam Bam is one that has 2 of those monoclonals in one preparation, and they infuse that, and it can greatly limit the severity of infection. And that stays present for not just a day or two. It can stay for weeks, if not months, and offer some medium term protection. So you're exactly right. It was the monoclonal antibody that I was referring to. So good call.
Yeah, well, thank you. And I just want to end by saying that, every time I do feel a little sorry for myself, I am reminded of the healthcare workers that are on the front lines, also police and fire and rescue folks. And but I particularly wanted to thank you, Secretary Carey, for your work, for putting yourself in harm's way to make sure that we have the greatest amount of protection and information, and we're able to access the vaccine and able to make our way on the other side of this. But thank you so much. And of course, thank you to all healthcare workers.
Well, and thank you so much for that. It's an honor to serve at this important time, and it is humbling work, but it is important work. And I just will say that in this role, I spent a lot of time supporting the recovery community through the behavioral health department of behavioral health, and there's a saying in the recovery world that our goal is to simply do the next right thing. And I think that message is not lost on us, dealing with so much uncertainty. Just keep doing the next right thing, and we'll get through this together. So
Well,
thank you so much.
thank you. We appreciate it. Thank you, everyone, for attending. And please show your appreciation to Secretary Carey. You can use your reactions, and you can let him know how much you appreciate it, or just plain clap your hands. That's awesome. And so thank you so much. Perhaps we can have you back at another time when we have better situations over healthcare. But we appreciate your time today, and we appreciate everyone coming to these Table Talks events. Remember that next month we are going to welcome the brand new Chief of Police for Henrico County, Colonel Eric D. English will be our speaker on March 18th from 12:30 to 2. Again, 12:30 to 1 will be our networking, and then we'll talk to Colonel English. I had breakfast with him, and wow, he's very interesting. He has a lot of thoughts about what he wants to do in Henrico and his vision for Henrico, and also really nice guy, but he has he's very, very visionary. So I think you'll enjoy that one as well. And we will continue to move forward with that. Please don't forget that we are going to, ladies, have a virtual IWOW at the end of March, and Innsbruck's Biggest Loser is currently going on. We have a wellness forum next Wednesday at 12:30, and we can always send you that information via email. We will be posting this link on LinkedIn, and also we'll send it to you by tomorrow in case you want to review it for more information. And I want to thank our special guest, Megan. Thank you for being here from Crossover Healthcare Ministry. Also, Elizabeth Mason with St. Joseph's Villa. Thank you, Ken, for sending me in the direction of Crossover. And let's all take care of each other and be safe out there on those icy roads. Thank you.